Hi, I'm Liz DeVos. I'm a professor of emergency medicine at the University of Florida College of Medicine, Jacksonville, where I run our global emergency medicine programs. Today, we're going to talk about some neglected tropical diseases that you may see in your own emergency departments in the United States. Thanks for taking the time to participate in this program and inviting me to give this talk to you. And in no matter what currency we're dealing, I have no conflicts to declare. Let's talk about the objectives for this lecture. We want to discuss vector-borne diseases likely to be seen in the United States due to shifting epidemiology. We will identify how to treat tropical diseases you might see in your own emergency department and understand what you would need to consult for admission and report to your local health authorities. Who's heard the term neglected tropical diseases? It's possible that you have not, because these are a collection of conditions that have received limited research funding due to the fact that the billion people worldwide that they affect often are underserved populations. These neglected tropical diseases are actually caused by a variety of pathogens: fungus, parasites, bacteria, toxins, and viruses. They have a complex epidemiology, and many different environmental challenges are involved, which make it difficult to do research on these. Furthermore, these underserved populations that are primarily affected do not have the agency to influence big pharma and development agencies' agendas, and that has meant that they have lagged behind in global health research efforts. As you can see, there are some things you regularly see in your emergency department on this list of neglected tropical diseases, as well as some that you've had on your differential before, and some you're scratching your head to remember if you even read about them in medical school. Luckily for the billion people affected worldwide, the WHO has convened a global roadmap for neglected tropical diseases. The overarching 2030 global targets are to reduce the number of people requiring treatment for NTDs by 90%, to reduce by 75% the disability-adjusted life years, or DALYs, related to NTDs, eliminate at least one NTD from 100 countries, and eliminate dracunculiasis and YAS globally. Since the implementation of the global roadmap for NTDs, the number of people requiring interventions fell by 80 million people just between 2020 and 2021, despite COVID's effect on progress. So we're finally moving in the right direction, but we have a lot of work to go. So here's where I'd toss you some candy if we were in a live lecture. But go ahead and jot down your answers and follow along. Do you know which NTDs are associated with these? That's right. This is a reduvid bug, or the kissing bug, and it's associated with Chagas disease. Chagas is caused by Trypanosoma cruzi, and it's transmitted in feces of blood-feeding tratomine bugs. As you see on the slide, up to 50% of tratomines in the United States submitted for testing at the CDC were positive for T. cruzi. Here in Florida, we have an active research program in Chagas at UF, and nearly 30% of kissing bugs in Florida tested by UF researchers carry the parasite that causes Chagas. But perhaps even more interesting is that more than 50% of possums and 40% of raccoons tested in the state also have the parasite, suggesting they too may play a role in the disease's transmission. Interestingly, it's not the bite itself that causes the illness, but feces from infected bugs inoculate the wound, and that causes disease. Patients can also become ill from feces that are transmitted by eating food where the bugs defecated. Patients who have blood transfusions, organ transplant, and other lab setting transmissions are also possible, although they're pretty rare. We've also estimated that as many as 10,000 locally acquired cases of Chagas have occurred in the United States, and we estimate that based on the blood donor data that is being tested. So what do these patients look like? The acute phase of the disease, which happens in the first 8 weeks of infection, can present with asymptomatic patients or patients with non-specific symptoms you see every day, the dreaded flu-like symptoms. On exam, they may have organomegaly or lymphadenopathy, or even a specific localized swelling called a chagoma, where the parasite entered the skin. You see that in the top picture. Also in the pictures here, we see Romagn's sign, or periorbital swelling syndrome. When we talk about periorbital swelling syndrome, we mean that there's periorbital swelling, palpebral edema, and conjunctivitis that's seen in the first 2 weeks following infection. When you see Romagn's sign, as you see in the lower picture here, you know you have a patient with Chagas. In rare cases, they may present with carditis, encephalitis, or meningitis. The acute phase lasts weeks to months and can resolve without any treatment at all. In the chronic phase, the vast majority still remain asymptomatic. This is also known as the indeterminate or latent phase, and up to 80% of these patients are asymptomatic at this time. If they do become symptomatic, many have cardiac manifestations, such as cardiomyopathy. That's a Chagas dilated cardiomyopathy in the X-ray from my colleague Norm Beatty's work. Patients also may have dysrhythmias, heart failures, and cardiac arrest. In the GI system, we may see megaesophagus or megacolon. All of this occurs because the parasite invades directly into the cardiac muscle and the GI myenteric complex, directly causing fibrosis and cell destruction. Diagnosis requires careful consideration to have it on your differential, since it's often presenting like a flu-like illness initially. You are not likely to make this diagnosis from the ED, and I wouldn't recommend sending PCR or blood smears on every patient you're seeing in the ED. Let's be clear about that. If you do have a patient with concerning findings, Romagn's sign in particular, you need to contact your local health department officials for testing directions. In Florida, they're doing screening drives on patients from endemic areas in Latin America in particular, as well as testing patients with cardiac conditions that haven't been explained by other testing. In patients known to have Chagas, EKG with rhythm strip, echo to assess LV function, and to rule out pericardial effusion are important. If the patient is symptomatic with toxic megacolon or GI motility problems, we need to work those up appropriately as well. All household contacts of patients need screening, and patients cannot donate blood. The WHF, World Heart Federation, guidelines for echocardiography in Chagas are also noted here for those of you who are really interested in global health ultrasound. Dengue and chikungunya. This one is your Aedes aegypti mosquito. And I'll give you credit if you got either of these. But dengue fever in Florida is on the rise. These are just some of the headlines from this time last year. And if you've been following, it hasn't gotten any better in 2024. In fact, today, my faculty meeting medical director brought up the concern of dengue outbreaks in Puerto Rico, and that we're expected to be seeing cases in Jacksonville next week for sure. Last month, it was the first time I had a colleague ever bring me bug spray in the hospital while we were doing ultrasound rounds in Paraguay. And her fellows were scanning the positive FAST and looking at pleural effusions in several children with dengue there in the emergency department. But dengue is not only in travelers. The vast majority of cases are, but in the United States, there were 407 cases of locally acquired dengue in the first 9 months of 2023. They occurred in Texas, Florida, and Puerto Rico. So we should expect to see some this year as well, since the worldwide dengue outbreaks have been quite severe. As you'll recall, dengue is an arbovirus and has 4 individual flaviviruses called DENV1 through 4. Over 75% of these are also asymptomatic infections, and many of the symptomatic ones are nonspecific. When we see serious complications, typically it's in hemorrhagic dengue causing plasma leakage and organ dysfunction, although Guillain-Barré and meningoencephalitis also can occur. Dengue symptoms are typically nonspecific. We may see fever, chills, rash, pain behind the eyes, nausea, vomiting, and bone and joint pain. You can make a diagnosis of dengue with 2 of the clinical findings in a patient with fever and exposure. So if the patient has the right history, a rash, myalgia, positive tourniquet test, leukopenia, they have dengue. And we also will look at the warning signs that alert us to know that these patients may go on to be severe. Things like abdominal pain and tenderness, persistent vomiting, accumulation of fluid like pleural effusions, mucosal bleeding, lethargy, restlessness, and hepatomegaly all let us know that we need to be on the lookout for severe dengue. In this picture, we see someone performing a tourniquet test. You need a manual cuff. Pump the cuff up to the pressure between the systolic and diastolic blood pressure. Wait for 5 minutes before deflating the cuff. Wait 2 minutes before performing your test and then count the petechiae in a 1-inch square. If there's more than 10 petechiae, it is a positive test. When we look at analysis of tourniquet testing for dengue, the sensitivity for non-severe dengue diagnosis, though, was 55% and specificity 63%, while sensitivity for dengue hemorrhagic fever diagnosis was 62% and specificity was 60%. So it's important to remember that this is not an end-all be-all. From 1975 through 2009, symptomatic dengue virus infections were classified according to a WHO guideline calling it dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. This is the most severe form of dengue hemorrhagic fever. The case definition was changed in 2009 for a more clinical classification after reports that the case definition was both too difficult to apply in resource-limited settings and too specific, as it's failed to identify a substantial proportion of the severe dengue cases, including cases like hepatic failure and encephalitis. So in 2009, clinical classification has been changed, but now is criticized for being overly inclusive because it allows several different ways to qualify for severe dengue, and non-specific warning signs are used as diagnostic criteria for dengue. Lastly, the new guidelines have been criticized because they do not define the clinical criteria for establishing severe dengue, except for providing laboratory cutoff values for the transaminase. Therefore, there's a lot of individual clinical judgment that goes into determining severity. In any case, we see that severe dengue is about 5% of people on their second infection. Though treatment is supportive, we can decrease the risk of shock and death below 0.5%. Findings in severe dengue include shock and fluid accumulation related to respiratory distress, hemorrhage and related organ impairment with decreased consciousness, cardiac dysfunction, and elevated transaminases over 1,000. Here you can see the initial phases of illness in dengue. Labs may show hyponatremia, elevated AST and ALT, and a normal ESR. As patients progress through an initial 2 to 7 day febrile phase and have injection of the oropharynx and redness in the face, usually this lasts a couple of days. Typically, it takes 5 to 7 days for incubation, and after defervescence, most patients improve, but some become severe. Patients can present with shock, narrowed pulse pressure, hemorrhage, and fluid leaks, as well as pancreatitis, myocarditis, and encephalitis. The convalescent stage, they resorb all of that extra fluid and continue to stabilize. At this point, some patients actually become bradycardic. Their skin also disseminates. Once again, this is a condition that I'd urge you to think about, but don't go trying to order it on every patient with flu-like illness. As you can see, during the febrile period, you can do viral testing like cultures and NNAT, as well as ELISA and rapid antigen testing. After 5 days, the testing is only ELISA. You're going to need to check with your lab and probably even your local health department to be sure you have the right swabs. Treatment is supportive care and avoiding NSAIDs to avoid worsening any platelet dysfunction. It's paramount to avoid further transmission. So good control measures to eliminate standing water, using bug spray and sleeves are very important. In Paraguay, when I was there last month in the PZR, these patients were placed under bed nights in the hospital so that mosquitoes in the hospital could not further spread the disease. It's important to note that thrombocytopenia in these patients should not be treated with platelet transfusion. This has been shown not to improve endpoints and possibly to add to the fluid overload. Similarly, only patients with autoimmune conditions like hemophagocytic lymphohistiocytosis and ITP should get corticosteroids. Prophylactic platelet transfusions in dengue patients are not beneficial and may contribute to fluid overload. The dengue vaccine, Dengvaxia, you've probably heard, was approved in the US in the last year or so. It is a live quadrivalent vaccine. It's only for patients who've had seroconfirmed prior dengue, as dengue-naive recipients can suffer antibody-dependent enhancement if they receive a vaccine prior to a natural infection. It is a 3-dose series and it's given 3 months apart each time. It's the only vaccine currently available in the United States, but the manufacturer is going to stop production due to poor demand. So again, here's another decision made by those who finance the neglected tropical diseases. The good news is 2 other vaccines are in trials. One is a single-dose vaccination that will review 5 years of data later on in June of this year. We believe it will be 80% effective in preventing dengue and can be used in dengue-naive patients. So stay tuned for the info on this. That's right. That's your friendly neighborhood 9-ringed armadillo. Oh, am I the only one who gets those digging out by my pool? They're associated with leprosy. As of last year, it's suspected that leprosy is actually endemic here. You may recall Hansen disease is the eponym for leprosy. It's caused by Mycobacterium leprae, which are acid-fast rods. They cause skin and nervous system dysfunction and are transmitted via respiratory droplet with prolonged exposures. There are some case reports of possibly local transmission. In Southeast United States, these are on the rise, with double the cases in the last 10 years. 1/3 of the cases that were acquired since 2015 are believed to be locally acquired. Here's a drawing of the lionine facies and the classic skin findings. On physical exam, the skin is waxy with papules as well as the blanching macules on extensor surfaces. These patients also have dysesthesias. On a radio interview, Dr. Nicole Iovine, the chief hospital epidemiologist at the University of Florida in Gainesville, said that leprosy can sometimes present like a rash with pigmented scaly skin lesions. And they can also have disfiguring nodules on their face or hands. But the main difference between a regular rash and leprosy is the loss of feeling in the affected area. You know, if you have something that's like a few centimeters on your arm and you can't feel it, that's going to be different from a typical rash, she just said. If you find these patients, they will need biopsies. Patients will also require reporting to the health department to be started on dapsone, rifampin, and clofazimine. Treatment is outpatient, but often multi-drug resistant, requiring at least 2 of the antibiotics from the list. Treatment will stop progression, but doesn't reverse the nerve damage. There's a national Hansen disease program throughout the country, and it's important to report to get patients connected to these resources. Here's a link from a Texas website giving us some information about how to report dengue in Texas. As you can see, it's reportable within 1 week. And there's a form linked on the website. Hansen's disease and Chagas are also reportable within 1 week in Texas. These can vary wildly by state, so it's important to know your local requirements. In Florida, many of these conditions require immediate or even within 24 hours reporting. And this is different than the reporting that's done by the laboratory. You need to look up your local requirements and know what will be reported for you and what you need to report. In my county, there's a fillable PDF that you print and fax in unless an immediate report is required by phone. So the key takeaways I have for you are that travel is increasing the ability to see any problem anywhere. But climate change and epidemiological shifts are putting more Americans at risk without travel. You must be thinking of these when you obtain your history, and you should know how to find local testing and reporting protocols so that you can do so in a timely manner when a condition is suspected or confirmed. Thanks so much for your time and your attention. If you scan this QR code, it will take you to a Google Doc where I've linked the folders with my references for this talk, as well as some other updates related to global health and infectious diseases. Feel free to drop me a line or to find me on X. Let me know if there's anything else I can help you with. I'd love to talk to some of you during the mentoring sessions. Thanks so much for your time and your attention. Have a great evening.